The first module for the respiratory system is mainly the anatomy of the system and the function of breathing. The overall goal is to describe how the respiratory system functions to maintain homeostasis, and with that the objectives are to identify respiratory organs, explain their function in the breathing process, distinguish between ventilation and respiration, explain how breathing is controlled and regulated, and then describe spirometry, which we will be doing in lab. Obviously, the most important thing about the respiratory system is getting oxygen in and carbon dioxide out of the body. Gas exchange must take place, or in about 4 minutes we're dead. However, the respiratory system also makes sound. The nose also allows for the sense of smell. The act of breathing, moving our lungs up and down, break up small blood clots, and breathing faster releases acid, helping us maintain pH. In fact, maintaining pH homeostasis is more important than getting oxygen in. This will actually harm us more quickly than a lack of oxygen will. Here are some of the anatomical parts of the respiratory system. Make sure you look at your list in your lab packet for these. The next few slides will show these in more detail. Here is a basic anatomy of the upper respiratory system. In particular, air travels from the nasal cavity down the pharynx, through the larynx or voice box, into the trachea, and then the primary bronchi. The tubes continue to get smaller until air gets to the alveoli, and that is where gas exchange takes place. The anatomy is roughly divided into two main areas, the upper respiratory system and the lower respiratory system. The upper respiratory system starts with the nose. This is the best place to take air in. The nasal cavity warms the air, moistens the air, and it cleans the air. It's much better for the lungs if you breathe through your nose. It is lined with mucous membranes which are ciliated. It traps dust and debris. Cigarette smoking can destroy these cilia, increasing the chance of infections because some of the crud and microbes are more likely to get to the lungs. The sinuses are spaces in the maxillary, frontal, ethmoid, and sphenoid bones. They make the head lighter. It doesn't weigh as much since we have those hollow spots in our bone. They too are lined with mucous membranes which drain into the nasal cavity. They are important for voice resonance. The pharynx or throat has three parts, the nasopharynx, the oropharynx, and the laryngopharynx, both for food and air. Only the oropharynx should contain food and air, although not at the same time. The upper respiratory tract filters the air that enters your body. Inside the nose, the nasal cavity, there's a sticky mucous membrane that lines it, and it goes around each of the nasal concha, increasing the surface area. The surface hairs, cilia, etc. move particles towards the nose to be either sneezed or blown out. The membrane lining the larynx and the trachea moves particles to the oropharynx to be swallowed. So the upper respiratory tract moves things either into the nose to be sneezed out or down to be swallowed. The lower respiratory parts start at the voice box where the trachea begins. The trachea or windpipe extends from the epiglottis to the lungs, where it divides into the primary bronchi, one for each lung. The primary bronchi then divide into the secondary bronchi, one per lobe, so 3 in the right lung and 2 in the left. The bronchi continue to branch, getting smaller and smaller and smaller as they lead to the alveoli. The lower respiratory part again starts at the top of the trachea, which is covered by the epiglottis. The epiglottis is a flap-like structure covering the opening of the larynx when you swallow. The larynx or voice box is made of cartilage, and the glottis is the opening between the vocal cords. The vocal cords, both true and false, are actually folds of muscle and connective tissue covered with mucous membranes. On the outside of the voice box, the cartilage of the larynx include the thyroid cartilage, forming the Adam's apple in men, cricoid and epiglottic cartilage. When air goes through it, the true vocal cords vibrate, creating sound, and the sound is changed by the lips, tongue, etc. These contain elastic fibers which vibrate to create the sound. We control pitch by changing the tension and control volume by changing the force of air through the vocal cords. The glottis, again, is simply the space between the vocal cords. The trachea, known as the windpipe, is lined with ciliated columnar epithelial cells, with many goblet cells secreting mucus. The structure is a C-shaped hyaline cartilage, so it won't collapse in on itself. Doing a tracheostomy is making a temporary external opening so air can bypass an obstruction. The lungs are soft and spongy and are supposed to be pinkish gray in appearance. They are located in the thoracic cavity, and more specifically in the pleural cavity. Remember, the lungs themselves would be surrounded by the visceral pleura and the cavity by the parietal pleura. Both touch each other as the lungs are expanding and contracting all the time as we breathe. The right lung is slightly larger than the left. It has 3 lobes and the left only 2, because the heart is tipped to the left side and takes up space there. The many blood vessels in lungs for gas exchange makes the lungs look pink. There are also lymph vessels in the lungs for fluid removal. The chest and abdominal cavities are opened here at autopsy. The lungs and the chest have a normal pink aerated appearance with minimal anthrotic pigmentation because this 80-year-old man never smoked and never allowed smoking in his workplace. The mediastinum contains mostly fat, which is normal, and the pericardial sac around the heart here has not been opened. The diaphragmatic domes extend upward to the level of the 6th rib. The second picture is a pulmonary artery showing a clot. The left lung here has a large pulmonary thromboembolus. Such thromboemboli typically originate in the leg veins or pelvic veins of persons who are immobilized. Other contributing factors include trauma to the extremities, hypercoagulable states, heart failure, pregnancy, and older age. The trachea splits into each lung, the primary bronchi then into each lobe, so there's 3 secondary bronchi in the right lung and 2 in the left, and then into smaller bronchioles, the alveolar ducts, and finally the alveolar sacs or alveoli. The cartilage and mucous membranes of the primary bronchi are similar to that in the trachea, but as branching continues, the amount of hyaline cartilage in the wall decreases until it is absent completely in the smallest bronchioles. As the cartilage decreases, the amount of smooth muscle increases. The mucous membranes also transition from ciliated pseudostratified ciliated columnar to simple cuboidal epithelial and finally to simple squamous epithelium. Alveolar ducts and alveoli consist primarily of simple squamous epithelia, which permits rapid diffusion of oxygen and carbon dioxide. Exchange of gases between the air in the lungs and the blood in the capillaries occurs only in the alveolar ducts and alveoli. The trachea, or the windpipe, is made of C rings of hyaline cartilage. It's about 6 or 7 inches long, and it does not collapse like the esophagus does. As they decrease in size, the cartilage, the connective tissue, and the hyaline and the smooth muscle of the first 2 decrease, and the smooth muscle increases slightly. All of the tubes are lined with epithelial cells because, remember, epithelial cells always line hollow organs and tubes. Most of them secrete mucus to catch debris in the cilia, the major defense of the respiratory system. Until you get to the alveoli, there are no cilia or mucus left. The alveoli are like bunches of grapes and have only epithelial tissue. This increases the surface area. If you laid all your alveoli out, it would equal to about half the size of a tennis court. So gas exchange can occur a lot. Oxygen and carbon dioxide both diffuse across the alveoli and then in and out of the capillaries right next to the alveoli. Both the alveoli and capillaries are just 1 epithelial cell thick, so diffusion can happen very rapidly. A couple of definitions for non-respiratory air movements are listed here. Coughing is a reflex which forces air up from your lungs, usually removing whatever is obstructing the airways. Generally, coughing clears the lower respiratory tract. Sneezing clears the upper respiratory tract, particularly dust from your nose. Laughing and crying is physiologically the same thing. It's when you take a breath in and release it in short expirations like ha ha ha. Sometimes you need to know a person or see their face to know actually whether they're laughing or crying. Hiccuping is a sudden inspiration due to the contraction of the diaphragm. There's no known function of the hiccup, and they think they increase when you're tired. Yawning is taking a deep breath when more oxygen is needed or perceived as being needed by the brain. And speaking is when you force air up through your larynx, causing the vocal cords to vibrate and make sound. And then of course we change that sound with our lips, our teeth, and our tongue. What part of the respiratory tract is lined with cilia? The nasal cavity, the pharynx, and the trachea, and a little bit into the primary and secondary bronchi. Oxygen is exchanged, however, only at the alveoli level. The next part of this slideshow talks about how we breathe. Respiration and ventilation are two separate things. Respiration is gas exchange, moving oxygen or carbon dioxide across the membranes of the alveoli and capillaries. Don't get this confused with cellular respiration. That's the breakdown of glucose. Ventilation is moving air in and out of the body. You can screw up your breathing by screwing up either one of these. If either one is inhibited or compromised, the body ends up with less oxygen, and that's not so good. Respiratory diseases are either categorized as a respiration problem or a ventilation problem. We're going to discuss ventilation first. Ventilation is moving air in and out of the body, and it completely depends on pressure. Air moves from high to low pressure. Because we cannot change the pressure in our atmosphere, we can only influence the pressure inside our lung cavity. The only way we can influence pressure is by changing volume. Pressure is related to volume in an inverse relationship. If you look at that equation, P equals nRT over V, the V is on the bottom of the equation on the right side. So as V gets bigger, P is going to get smaller. The other things that pressure depends on is the N and the R and the T. This is the ideal gas law, but we can pretty much ignore that because N is the number of moles of the particular gas, which again, we can't control the percent of oxygen in the air. R is a constant, and T is temperature. We cannot control the outside temperature, and the inside temperature is generally around 98.6. So pretty much we only need to worry about the P and the V in this equation. Just put a 1 on the top and cross out the N and the R and the T. So when volume goes up, pressure goes down. And so when we increase the volume of our lungs, like when we inhale and our ribs move up and out and our diaphragm contracts and moves down, the volume gets bigger, the pressure gets lower. Remember, it goes the opposite. And because pressure now is lower than the atmosphere and air goes from high to low pressure, it will rush in. When we exhale, the opposite happens. Our volume gets smaller as our ribs go in and down and the diaphragm moves back up. The pressure in there gets higher and it's going to move out from inside our body to out into the atmosphere. So again, inspiration, the pressure inside needs to be lower than the atmosphere. And the only way we can make that lower inside is to make the volume bigger. So notice, when air's coming in, the ribs are up and out, the diaphragm contracts and it moves down, makes the whole cavity bigger. So the cavity enlarges when the diaphragm contracts and the ribs move up and out. This makes the pressure inside lower and air rushes in. The opposite happens during expiration. For air to leave, the pressure must be higher than the atmospheric pressure on the outside. So to make pressure higher inside, we got to do the opposite to the volume. We got to make it smaller. So the cavity shrinks, the diaphragm relaxes and moves up, the ribs move down and in. Because this is a relaxation process, you can't force it. So exhaling or expiration is a more passive process, and mostly you need to let it happen. Here's another picture comparing the two. To inhale, you need to make the cavity bigger so pressure is lower than outside and air will flow in. To make it bigger, the diaphragm contracts and moves down and the ribs move up and out. To exhale, the cavity must get smaller so pressure increases so air will move out. To do this, the diaphragm relaxes, moves up, and the ribs move down and in, making the cavity smaller and air is forced out. Although the cavity changes shape, the alveoli do not collapse even though they're wet and the pleural membranes are moist. Think about a cover slip and a slide when they're wet. They're hard to separate. The reason there is not a collapse is due to a chemical called surfactant, which is not made until you're born because you don't need them to exchange oxygen inside mom. You're getting oxygen from mom's blood. This is why preemies didn't live very long until we discovered a surfactant and figured out how to make it, and we can now put it in the ventilators for baby or for preemies. Surfactant reduces the surface tension throughout the lung and thereby contributing to its general compliance or ability to expand and contract. It's important because it stabilizes the alveoli. Respiratory volumes can be measured using a machine called a spirometer. We will do this in lab. The following list is different respiratory volumes that are measured, and about what the average volume is for each will be named. After defining each, the next slide shows this by graph, and it may be easier to picture that. Respiratory cycle is the amount of air that goes in and out, or when air goes in and out. The normal amount of air that goes in and out during a normal respiratory cycle is called your tidal volume. The normal breathing volume is about 500 mils, which is about the size of a bottle of water. After you take a normal breath in, you can force more in, and the amount you can force in is called your inspiratory reserve volume, and it's another 3 liters. You can also force more out after a normal breath, and you can force out another 1100 milliliters. The 3 of these things added up together, tidal volume, IRV, and ERV, is the amount you can forcibly exchange. So you take as deep a breath as possible and push everything out. That is your vital capacity. Okay? And that's what we will measure in lab, in the spirometry lab, but with the spirometers. The functional residual capacity is the amount of air remaining in your lungs after a normal breath out. Okay? And this can be reduced in people with asthma because they aren't able to force air out very well because of the constriction that's going on because of their asthma reaction. Residual volume is the amount that's always in your lungs. You cannot force all the air out of your lungs. They don't completely collapse every time you breathe out. This is about another 1100. So your total lung capacity is your vital capacity plus what's always in your lungs, or your residual volume. It's about 5,800 milliliters, but it varies widely depending on how big you are. So here's a picture of the volume of the respiratory volumes we just discussed. The tidal volume is in the middle here, the amount that's normally exchanged. And then the amount you can force in is above that, and the amount you can force out is below that. So together, these 3 add up to your vital capacity. This is the most common thing measured by a doctor. Functional residual capacity is the amount left in your lung after a normal exhale, and your total lung capacity is your residual volume, what's always in your lungs, and your vital capacity. Why would they bother to measure this? Vital capacity is measured to help diagnose lung diseases or determine the severity of a neuromuscular disease. It's also measured a lot in people with asthma to determine if their asthma medication is working. Height increases vital capacity and age lowers it. Although long-term exercise or physical fitness can increase your vital capacity, it generally is set by your age, your sex, and your height. Sometimes swimmers and opera singers who practice deep breathing techniques can have an increased vital capacity. The last thing we're going to talk about is how we control our breathing. Okay? The first thing that controls our breathing is the lowest part of our brain stem. And that would be the medulla oblongata. The normal breathing is rhythmic, and the rate is controlled. And if your body senses that you stop breathing or you're not breathing quite as deeply, maybe you're starting to fall asleep in class, the phrenic nerve triggers the diaphragm to speed it up. This is especially true if we have low oxygen, high carbon dioxide, or high acid in our blood. In fact, these are listed in the opposite order of importance. High acid will increase your breathing rate much quicker than low oxygen will, actually. Okay, so high acid and then high carbon dioxide and then low oxygen, which are detected by chemoreceptors, will trigger breathing rate to increase. And the medulla oblongata, the base part of your lower brain stem, is involved in this. The pons is also involved, which is the part of the brainstem right above the medulla oblongata. Stretch receptors can detect how deep we're breathing, and again the pons can sense this and helps maintain regular breathing rate. Sometimes emotions can also change breathing rate. When you get excited or you get scared, the sympathetic nervous system will kick in, and epinephrine will increase breathing rate and also dilate the bronchial tubes. However, the lower brain areas will take over if the higher brain is damaged or not functioning. Breathing is self-regulating for the most part. You cannot hold your breath and kill yourself. Eventually you'll pass out, and the medulla oblongata and pons will kick in and maintain normal breathing rate. Rapid, deep breathing or hyperventilation leads to a loss of carbon dioxide, and that is called and that will slow breathing rate. However, if you slow your breathing rate too much or purposely hold your breath or have a respiratory disease where you can't exchange gases, CO2 will build up in your blood, and that is hypercapnia, and that will trigger an increase in breathing rate to try to get rid of that. Decreased blood pressure can also increase breathing rate, because without blood pressure your tissues aren't getting oxygen, and this will trigger an increase in breathing rate. So the baroreceptors that are detecting your blood pressure can affect breathing rate. Inflation and deflation reflexes, stretch receptors detect changes in the diaphragm and rib cage, and again the pons regulates that. There's also some protective reflexes like coughing and sneezing to expel pathogens and debris that may affect breathing rate as well. If you need more information about the respiratory system, don't forget any book will work, the online text, the lesson. There's some good websites here, and your lab book. You should come to lab. It will really help with the respiratory system.